It is an absolute pleasure for me to now introduce you to Jillian Macklin. So she holds a BMSc from Western University and an MSc in Laboratory Medicine from University of Toronto. She is now an MD PhD trainee at the University of Toronto and currently in the third year of her PhD in Health Services Research at the Institutes of Health Policy Management and Evaluation. Jillian's research focuses on community engagement, marginalized populations, and inclusive medicine. And so this work as well was funded by the Strategy for Patient-Oriented Research, or SPORE Evidence Alliance seed grant. So Jillian, over to you.
Perfect. All right. Thank you so much, Andrea. Hi, everyone. I am Jill, and I'm really happy to be here to present on our work on patient engagement in AI development in healthcare. And so again, just like the presenter, I just want to thank you for the support and the space for growth as a trainee to be part of this SPORE Evidence Alliance and to tackle this work this year. I would like to just start with a land acknowledgement. So I'd like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the University of Toronto now stands. And I'm thankful to work, play, love, and grow on this land. So as for learning objectives, and I hope we can have some time for questions and discussion at the end of this presentation, but really what I want everyone to start thinking about is to understand the scope of the literature to date on patient engagement in the development of artificial intelligence applications in healthcare, to explore from multidisciplinary perspectives the facilitators and the barriers or the potential barriers to patient engagement in AI and the methods to be used in the future. And then finally, reflect on how to ensure patients will have a seat from the very start in AI development conversations in healthcare. And so artificial intelligence, I think we've all heard this word. It's buzzing around the last few years, but really it's actually a broad term that was first introduced a long time ago in 1956. And so AI can be simply defined as a machine behaving in ways that would be called intelligent if seen by a human. And we often think about AI as a field of study in computer science, machines, comp sci, but it's really a broad field of study. It includes psychology, philosophy, linguistics, and many, many others, including medicine. And so really AI is already here in healthcare. We see it everywhere. And really the big reason why there's this push right now is because of big data. So there's new opportunities are being opened by the continuous expansion of the possible uses, sources, and types of big data. For big data on health, the stakeholders extend far beyond clinicians and patients. They extend to businesses, development agencies, national governments, and many professional societies. And so it's helpful to think of it as an evolving ecosystem. So if we think about one patient, there's this sheer amount of data we can get. There's genomics, transcriptomics, lab values, telemonitoring measures. We need a way to keep up with it and keep up with the ecosystem as a whole so that it's helpful and collaborative in healthcare. And so I wanted to run through a few examples of AI, just so we're kind of all on the same page of how AI could be used in healthcare. So one example of AI is machine learning. So it's where a model learns from experience acquired from engaging in certain tasks, and where its performance on these tasks improves with more experience. And so an example of this is right here in Toronto called Medley. Medley is a heart failure remote monitoring application. And so somebody at home who has heart failure can input their symptoms and their weight measurements and their blood pressure measurements into this phone. It goes through a validated algorithm and then outputs data to both the patient and to the clinician. So for example, if your weight is different than what your threshold should be, and it's personalized to you, you'll be alerted that something is off. Your clinician alerted that they need to change some sort of form of management. And the machine can continue to learn the patterns of that specific patient so it can get better at tracking false alarms or actually providing management tips itself. Another form of AI is what we call deep learning. And so some complex language here, but deep learning is kind of going a deeper layer into this machine learning. It's using deep networks with many intermediate layers of artificial neurons between the input and the output. And these artificial neurons learn a hierarchy of progressively more complex feature detections. And so a really good example of deep learning is the way that perhaps in the future we will be diagnosing skin cancer. And so a really, really big paper in Nature in 2018 came out that instead of diagnosing skin cancer using, histology and a biopsy, you could take a photo of the skin lesion, and through some of these deep neural networks, you could have a diagnosis that is good, if not better, than a clinician doing their standard of care. And then finally, a third example. So natural language processing is another branch of AI. And so we immediately go to clinical notes or EMRs when we think about NLP. So NLP is a tool combining linguistic, statistical, and heuristic methods to analyze free text. So analyzing paragraphs, analyzing words, analyzing roots of words to be able to categorize and tag written or spoken word. And so another example of this right here in Toronto is called Autoscribe at the Department of Family and Community Medicine, where an NLP with a microphone can listen into a clinician-patient relationship and record it and actually spit out a clinical note. And not only a clinical note, but a note that's tailored to the style and to the way that the clinician usually writes their notes, because it can continuously learn. And so, of course, we think about how much time that could save a clinician when they're speaking to a patient in an intimate conversation. So listening to these examples, I'm sure going through your head, there's concerns, there's questions, there's ethical dilemmas of AI in healthcare. Of course there is, right? So algorithms that are biased towards certain groups. Black versus white skin in dermatology. There's questions about, did patients consent to their data being used to train these algorithms? How does it feel for a patient and a clinician to use an algorithm that they don't really understand, this black box phenomenon? How do we ensure AI applications made by the private sector are safe to use in the public healthcare sector? What are the most pressing needs of the healthcare system that AI can improve? And then how do we ensure patients have an understanding of where their data is going? So all of these questions are very important. And for us to answer many of these questions, patients should be at the forefront of the conversation. They are the end users of AI applications in healthcare. So defining patient engagement, we probably don't need to define it for this group, but this is the definition I'm using. It's occurring when patients meaningfully and actively collaborate in the governance, priority setting, and conduct of research, as well as in summarizing, distributing, sharing, and applying its resulting knowledge, with some key principles down at the bottom. We know the benefits of patient engagement. We know that patients can set priorities and goals of care in this setting of innovation. They're fully capable of that. And also the benefits are shown in the data. There's a reduction to healthcare costs, fewer hospital admissions, increased patient outcomes, increased quality of life, improvements in patient safety, and most importantly, in my opinion, patient empowerment. There is also quite a bit of data out there on how to achieve success in patient engagement. And so from Manafo's work, which I've learned a lot from, some of these key recommendations of how to achieve success with patient engagement, many of which resonate for AI development in healthcare, such as engaging patients as early as possible throughout the process, clearly defining what it means to engage, having adequate training and resources for patients to be able to engage. Many of these recommendations got us thinking in this context. But so the objective of this work, number one, was to do a systematic review. And that is because we were not sure the landscape of patient engagement within the AI health ecosystem. And so in consultation with 2 patient partners, we studied whether patients were engaged in the development of AI applications in healthcare, and if so, how the engagement happened. And so we searched quite a few databases here, Medline, Embase, Web of Science, and all, as well as the gray literature from 2000 to 2020 with a refresh in 2021. And so we were looking for English articles globally that first described development or the design of some sort of AI application in healthcare that's part of patient care delivery in any healthcare setting. And of all of these applications, we then looked for ones that had active patient engagement during any developmental stage of that application. So we could have this percentage of how many applications had engagement. And when we finally analyzed this using a meta-narrative approach. And so this was the framework of our analysis. So first, was there engagement in the AI applications development at all? And if so, what method of engagement was used? What stage of development were patients engaged at? Who was engaged and how were they recruited? What are patients' perspectives on the AI application in healthcare? What were the facilitators or the barriers to the engagement? And then finally, what was the impact of that engagement and what benefits did patient engagement bring? So the findings in general, we had 8,697 unique citations where we identified 700 eligible articles on an AI application in healthcare. Of those 700, we only identified 37 studies, which is approximately 5%, extremely low, that reported any form of patient engagement. Most frequently, they were done in the USA and the UK, and 75% were done 2018 onwards, which is married to the fact that AI is quite common in the last few years. A variety of applications of AI were found, such as mobile coaching, all the way to diagnostic support. And the most common reason for this AI application development was for chronic illness management. Now for the findings of the engagement itself. So about half of the engagement was using survey methodology. So a survey on patient satisfaction, acceptability, usability, those sorts of things. Other methods included interviews, design workshops, and observations of a patient using the AI application. Only one study justified the reason for the use of this method to engage. Only 3 studies used inclusive patient engagement language, such as co-design, co-create, or naming patients as experts. 8 studies included caregivers in the definition of patient engagement. The spread of patient engagement activities along the continuum of developmental stages was really a spanning from idea conception all the way through to dissemination. But you can see by the numbers here, a lot of the engagement happened early, idea conception, development, piloting, and there was no engagement in the dissemination or knowledge translation. And then finally, 50% of the studies reported demographic information of the patients that they engaged, the majority reporting on age and sex, some studies reporting on ethnicity or education or income level, and very, very few studies going into the depths of some of the other information, such as their familiarity with technology, languages, religions, or if they were in an urban or rural setting. The patient perspectives that we found from these engagements was really a mixture of hope and skepticism. So one study actually reported that 20% of patients considered the benefits of AI to outweigh the risks. And so, that there's some skepticism that chose to engage of, is AI really something they're comfortable with in healthcare? Biggest perceived benefits from a patient perspective was having a machine alert them at home, having more accurate diagnoses, and clinicians being able to give some of those mundane administrative tasks over to a machine. From a patient perspective, the biggest concerns were that a machine could lack empathy, the problem of explainability. So can a clinician or a patient be able to explain how the machine gets to the answer that the machine gets to? And of course, information privacy of AI. And then facilitators, barriers, or the impact of patient engagement. In the literature, there were no reported facilitators of how they did meaningful engagement. They did have reporting of a few main barriers. So a barrier for patients to engage in AI development was the digital divide. Patients not having access to the technology to be able to engage. For people that were quite unwell, there was barriers of them taking that step to engage in technology. And then of course, the barrier of technology literacy. And then in terms of impact of having patients engaged in these studies, 5 studies reported impact, and it was mostly making the AI application more accessible, more user-friendly, more patient-centered, and having a more widespread adoption. So our recommendations from this work, you know, we're still playing with them. We're still trying to find the best way to make these recommendations from this review. But number one, increasing patient engagement research rigor. And so, you know, having studies actually define what patient engagement is, having a conceptual framework, having a way to evaluate that patient engagement and having that a core piece of their AI research. Number two, continuing patient engagement beyond piloting stages. And so we saw that there was no engagement in dissemination. And so for a topic as complex as AI, we want patients to be engaged at the end where we're trying to show meaningful knowledge translation to the community, and quite a difficult thing to knowledge translate. Number three, comparing clinician and patient engagement findings. And so really seeing how clinicians and patients both view the use and the adoption of AI in healthcare, because they're the core center of a therapeutic relationship. And number four, ensuring equal opportunity in patient engagement in AI, because we know that it's a complex topic. We know that we need a lot more diverse folks at the table. Currently, it's younger folks, white folks, and folks who are quite comfortable with technology that are the people engaging in this topic. And so this moved us to a rationale for objective 2 of our study. And so we saw in the literature that patients are identified as key stakeholders in the design of AI healthcare applications, but we've seen from the literature review that they've not been engaged appropriately. And so the method of patient engagement in AI development in healthcare has not been previously studied, and currently no guidelines exist. And so in order for patients to have meaningful participation in the eventual development of guidelines, we're pre-guidelines for patient engagement in AI health research, we must thoroughly understand what methods are best suited for engagement in the first place. And so that's where we're at now. We created a study that seeks to understand from multiple perspectives the most effective, feasible, and preferred method to engage patients in the development of guidelines for patient engagement in AI health research. And this study utilizes an exploratory qualitative design using focus groups to engage various stakeholders. And so the various stakeholders that we're talking about include patients and caregivers, healthcare providers, policymakers, government data managers. So for example, someone from the Ontario Health Data Platform, and then AI developers in industry. And so we'll have 2 focus groups for each of these groups individually. And then we'll have 2 focus groups later on, mixing people from each of these groups so we can see how ideas converge and diverge. Before focus groups, we'll have a demographic survey to ensure that we have a diverse group of folks at the table. And then in the focus group, we really just want people to think about, you know, how can we best engage patients in this development of guidelines? What are the methods? What steps should people be engaged? And really think about what we ought to do that is best for everyone. And I'm sure there'll be tensions between different groups. And the goal then is to eventually bring a multidisciplinary table together to start planning for this guideline development. Before focus groups, we've given folks a primer or a module on AI so that everyone can be on the same page. So some of the terminology that I've talked about, like machine learning or deep learning, some of the ethical pieces that we think about when we think about AI. This primer, for some people, like an AI developer, is probably not new. But for others, such as a group of patients, it might be the first time that we're delving into this stuff. But it's important that everyone has that same knowledge base, so when they do come together, we know where each other are at. And so we've taken this module, gotten some feedback from patient partners, made it a little bit more interactive, and we're hoping to post it online through the Department of Family Medicine so that it's a resource not just for clinicians and patients, but for the public as well, to just, you know, have that base knowledge of AI that could be used in their care someday. We've done 2 patient focus groups, and the rest will be done in January, in individual health leader focus groups, as well as these mixed focus groups. The initial patient perspectives that we've gained are the fact that patients are not at all surprised about the literature findings, that there's very, very little engagement in this space. They talk about a lot AI complexity, the fact that it's intimidating, and why many patients have not pushed to be engaged. It's not something that they can bring up with their clinician that they trust. It's too short amount of a time to be able to bring that up. We're also hearing in focus groups that patients do want to be engaged from the very beginning with the brainstorming phases and the prioritizing ideas on what we can tackle with AI. They don't want to be brought an AI application that's already developed and asking opinions on that. In our focus groups, patients did say that a roundtable having patients, clinicians, and leaders all together is very necessary for this guideline development, but ensuring ways to make sure that patients still have their voice when they're in that room. And then finally, patients would like a survey to be sent out so that we can understand what type of training and resources that they'll need to be able to engage in this work. So what's next? We're doing concurrent data collection and analysis using interpretive description. And so we're taking this focus group transcript and doing an inductive analytical approach to create ways of understanding this clinical phenomena that leads to practice implications in healthcare. Interpretive description is often used for multidisciplinary perspectives, such as what we have here. We'll be inviting some participants from the focus groups to a collaborative planning meeting this spring with other stakeholder groups, with other academics, to review the focus group findings, to discuss future work, and to plan a grant to be able to support formal guideline development of how to engage patients at each phase of the development process of AI applications in healthcare. And really, this is the first instance that we're aware of studying engagement methods in the context of AI development in healthcare, and forming this multidisciplinary network in this space is something that's quite exciting. Like we said, quite intimidating for some folks, but absolutely necessary to bring in this engagement into the technology space. And so with that, acknowledgements and thanks. The Upstream Lab, Dr. Andrew Pinto is my supervisor for this work. Samira Edu is a medical student that we had with us in the summer that drove a lot of this work forward, as well as Rose Wang with her constant administrative support. Again, thank you to the Spore Evidence Alliance, to the Department of Family and Community Medicine, and of course to research participants and our recruitment partners who made this work happen. So feel free to contact me through email, through Twitter, and happy to discuss.
Excellent. Well, thank you so much, Jillian, for such an informative talk on a topic that I think many of us are really fascinated and interested in. So there were some questions in the chat. Megan, did you want to read the first one? Because there were a couple.
Sure. So first one is from Kathy Kastner, and she said, not sure if it's within scope, but would the output be input table to other systems for interoperability?
Kathy, I'm not sure if you wanted to unmute and just explain further. I'm not sure about the
hell I'm talking about. What I'm actually asking, I'm thinking the data so I'm a patient, and I'm thinking that eventually, I'll input something into my whatever, my data will be collected and AI'd, and then what could happen to it afterwards? Could it be put into my own patient portal? Could it be shared with another institution that is also as caretakers at their institution for me? Is it shareable? Like I said, yes, that's
yeah. So that's exactly one of the concerns that we would want to bring up at one of these roundtables, and having your perspective on that, because currently, you know, AI is being used here and there. Currently, there's not that consent process for us to be able to ask a patient, where do you consent this data to go? Would we be allowed to use your data for this machine? Or would we be allowed to send it to another provider? We're not doing that correctly right now. And so having these discussions with folks about, you know, where is our comfort level? And then how are we able to explain to the public what our processes are for AI applications?
Thank you for that explanation. Of course, the whole consent thing just flew out of my mind. So thank you for that.
You're welcome. Thanks for the question.
Great. And just being cognizant of time, do you think, Megan, we have time for maybe one small question?
Yeah, I think so. I think we can get the next question in. So from Joanne, she said, exciting and fascinating. Going forward, will you target patient partners who have a background in IT in particular?
Great question. So I think there's room for patient partners with diverse backgrounds, and we would want someone perhaps that has that complex IT background, but also folks that have no IT background. You know, to ask some of these questions of just, can we bring it down to a level for everyone to understand and then work from there? And so currently we have a team of 2 patient partners, and they're, you know, one is coming from a math background and one is coming from an arts background. And to see the way that they discuss things is fascinating and extremely important for us.
Great. Thank you so much, Jillian. And unfortunately, I think we're running short on time right now. But thank you so much for your engagement. And maybe Megan, because there's quite a few questions and enthusiasm here for you, Jillian, in the chat box. So perhaps Megan can connect you through email after we finish here today, so that you don't miss the important questions and see all how everyone is really excited about your work. So really well done and great presentation. Really enjoyed that. So that concludes the last seminar series for Knowledge Translation, or KT Canada, of the year. And I think it was an amazing session. I think we can all agree to end the year with. So thank you, all of you, for attending. Thank you for all of your questions. A huge thank you to our presenters today who did just such a fantastic job. There will be an online evaluation, so the link should be in the chat there now for you. Here we are, so definitely please fill out that evaluation, because that allows us to improve our sessions and as well as helps us to plan for future sessions. And on that note, our next session will be Friday, January 14th with Dr. Janet Squires, who is someone I'm incredibly fond of. She's fantastic, so do not miss that session. And she's going to actually be working or talking about de-implementation, which is a very important talk. So often we focus on implementing things. Well, how do we de-implement innovation? So definitely be sure to make that time for that talk. I would also like to thank Megan Story for organizing everything and making sure that everything went smoothly today, and for all that you do, Megan, behind the scenes. You're just amazing, and everyone just loves working with you. So huge round of applause to Megan for everything that you do. You're amazing. And I think with that, I just want to wish every single one of you here, so everyone, just a very happy holiday season ahead. Hope you all take some downtime. Please take vacation time, everyone. Self-care is so important right now, especially after the last couple years that we've had. And so I hope everyone gets a chance to connect with your loved ones, so your families and friends, of course, safely, knowing that we still have to protect ourselves with the variants circulating and everything else. So, you know, just best wishes to all of you, and looking forward to seeing you in the new year. So thank you again, everyone, and please take good care. Thank you.